on for liver lift back there. Okay, all joking aside, this was something I'm doing all the time. It is heavy-handed. Nothing's going to be done to you quickly or that you don't want done to you. I don't do any of that. I don't do anything by surprise. So there's an energetic aspect of it. That's how we're going to start off, nice and easy. Try and feel some rhythm. Again, some of you are going to feel it, some of you aren't. Some of you are going to feel it later. Maybe you'll have difficulty with it for a long time. I don't know. The idea of these seminars is I'm teaching people who are already educated in palpation, giving you a set of skills. The whole plan is you go back to your practice and you have to start trying these things. You don't have to necessarily be successful, but you have to start trying to incorporate these ideas. You're always going to find some things. You tell them, go all the way out of the room. If you're going to have a call, I don't want to hear it. So go up the door. Go up the door or go in the other room. Don't walk around back here and have a conversation. I don't want to hear it. So, because it distracts me. When he's got him. So, and I understand business, families, whatever. But make the call. Go upstairs. Go out there. Go into the street. Go into Kolkata. Have the call there, so that you can have your call in privacy and I don't hear anything. Keep in mind that all these skills, some skills you're going to get, you're going to absorb them right away. Others, it's going to take time. And maybe the light goes on 6 months from now. That's how it worked with me with Visceral. I've given you my short soliloquy on it, which I'll repeat again. When I first learned Visceral, I had a very good teacher. Everybody in the class was feeling all this energetic stuff, or lying that they were feeling this energetic stuff. I didn't like the explanation, and so I threw it in the trash can. Never did any of it until about 6 months later. 6 months later, I had this, she was a big lady, she had a car accident. She was like late 30s, maybe early 40s, black woman. I mobilized everything, did soft tissue, did cranial center, love energy, nothing worked. Okay, her shoulder was like this. I said, all right, let me try and do that, something else. So I want to do a liver lift the way I was shown. Couldn't get my arms around her because she was so big. So I just did a one-hander around here, lifting her liver, and got like almost a normal range of motion like that. Then I went backwards and said, maybe it wasn't all crap. Maybe there was something to it. That's how I got into it. Didn't feel visceral rhythm for a long time. So don't worry about what you don't feel. Also, if we have some time in between, if there's some questions you still have on cranial or the SBS diagnosis, we can do some quick reviews of that as well. Okay, any questions before we start on anything? Oh, some of you I know are pretty sensitive to touch. So when you're working with your partners, let them know if it's too much. You're going to see when I do it, because this is a safe place, I'm going to do it strong on you, okay? Because I have no fear, and I've been doing it for 30 years. So this is a safe place for you to see it strong. If you're feeling uncomfortable, you tell me to stop, I stop. If your partner's making you uncomfortable, you have to tell them. I'd prefer you tell them rather than coming to me at lunch and going, I'm dying. Okay, tell the person who's killing you to slow down on the killing you during the killing. All right, let's get started. Visceral, by the way, you know, if you still didn't look at the body in these different similar ways that we look at today, to study anatomy and physiology, do whatever you do to try and fix the problem. We know he did visceral stuff and he referenced these ideas, not because he was being secretive. He wanted people truly to understand the anatomy and physiology and then create whatever it is they got to do, not just follow the book, step 1, step 2, step 3. So he did things that for sure would have to be called myofascial today. In the visceral world, some of the things we're doing is visceral, absolutely you can call it myofascial. If you want to have an argument and wave flags, who owns the technique? You can't stick your fingers deep into somebody's abdomen saying you're doing a fascial technique that doesn't affect things around it, the viscera, and vice versa. Okay, so let's just talk about our concepts and our general anatomy. Two concepts we have. one is mobility and one is motility. Mobility, everyone in this room will be able to do. At the end of these 3 days, for those of you who are alive, you will be able to do visceral mobility to your patients. Everything can be done, mild, moderate, nuclear, okay? Keep that in mind. So when you say to me, Dr. Santa, would you do this to that kind of patient? Mild, you can do to darn near everybody. So it's a gradient, okay? Mobility is something that we can grossly see happen. Put you under fluoroscopy, we can see that your liver, which holds about 20% of your body's blood, your liver is moving 3 to 5 centimeters when you take a breath in and breath out. That happens. Motility is going to be like the cranial rhythm idea. To my knowledge, no one has proved this in any scientific way or reproducible way. It's just a bunch of weird people who all agree we feel this weird thing. And there seems to be some benefit from it. My proof for the benefit is do a lot of motility on babies and their symptoms improve. The reason why I say babies are my proof is because adults, I just never know. I'm doing a lot of different things to you and maybe you get better. I ask you if you're getting better and maybe you lie to me because you want to give me an answer that you think I want to hear. It's all political, you know. Babies aren't. I showed you the happy faces of how much the babies enjoy me touching them. So, we're going to go back and forth with these two ideas. We'll work a lot on motility, trying to feel this subtle rhythm, and then we're going deep, like a submarine going down to the Earth's core, where the molten lava is. I have been told in every visceral course that I ever attended, make sure your patients don't eat before they're going to get treated. Did you all enjoy your snack this morning? In Indian culture, generally speaking, how many meals a day do you eat?
3.
3? Might have a snack in between? 4. Okay, let me tell you about American culture. We only have 1 meal a day. 1. It starts when we wake up and it continues until we fall asleep. Okay? So people will come into my office with their bags of food, like they're never going to see food again, stuffing their holes. And the bigger the patient, the bigger the bottle of water they have. They do have a bag from McDonald's, but the bottle of water. You may as well just go full bore of the poison if that's really your diet plan. So my point is I've never had anyone, I've never given them that story. It doesn't matter. I was told that it matters, it doesn't matter. And it would be impossible in America. Everyone ate just 6 minutes ago. That might be the longest stretch of time. And I want to tell you that I've never had an adult throw up in my office. I've had people tell me they went home and got sick and threw up. Sure, I've had that for a variety of reasons, not just visceral. And I've had kids throw up, but they throw up because they're mad. They get themselves worked up. It's not because I'm using such heavy pressure. It's because they're getting themselves worked up and they throw up that way. So throwing up is not a fear. It's not a reasonable fear. Okay, so these two ideas. Motility is something that happens on its own. It's that little dance that the liver's going to do. Some of you will feel it because you are spiritually advanced and God loves you. Some of you will not because you are possessed by the devil and have to amend your lives for the evil things you have done over the course of your lives. Like me. That's why I didn't feel anything for 6 months. If you can't feel the rhythm, the best way to feel it is to do this. Why can't I feel it? What's wrong with me? Okay, that will help you to focus your energies on why you're unable to feel something. If you can come up with some curse words and some foreign languages and apply these to yourself. I'm making all this idiotic humor because at any given moment, I'm barely holding on to sanity. Holding on by my fingernails. The other reason I'm being so silly about it is I need you to just chill, okay? You don't feel it, you don't feel it. The more you think about it, you become your own worst enemy. At some point, I think if you practice enough on patients, and what I mean by that is if you have 30 minutes to see a patient, carve out 5 minutes and say, put my hands here, my hands here. What are you doing, doctor? Just feeling for tissue tension. At some point, I think you will feel something other than respiration. What I'll say to you is the moment where you're feeling something other than their respiration and their pulse and things that their MDs are feeling, treatment is happening at a deeper level. I don't care what you're doing, cranial, visceral, counterstrain. The therapy is happening at a deeper level the moment you're able to recognize that, because you are more intimate with them. Okay, what I'm going to do now is just give you a general overview of the abdomen. We're going to start out very light. Nothing is done sudden or unexpected. So these are the same slides I showed you in cranial when we talk about body rhythms. When we talked about the cranial rhythm, we compared it to the cardiac rhythm. Everyone knows that in medicine. No one argues it. The heart squeezes. We feel an event go through the whole body. Because of the action here, we feel it everywhere. Respiration. You take a breath in. If we exaggerate it, all the bones externally rotate, internally rotate. It's a palpate everywhere. Cranial, palpate everywhere. Some of you are, if you can feel it on the head, you can feel it on the feet. There's no difference. There's no diminishing of that wave. We'll talk about wave mechanics in the advanced cranial, but waves don't diminish over time. People tell you that, like, the cell phone causes cancer, brain cancer. You've heard this, right?
Yes.
You've heard it.
Yes.
Yeah. It doesn't matter whether I hold the phone here. I'm subjected to the waves of all of your phones and everywhere. Waves don't diminish over time. That's their nature. Oh, you're bringing the focus of the waves to your head. Okay, get rid of your cell phone, go back to that big megaphone thing like this and just scream across to the other county. Visceral rhythm is the slowest rhythm. We're giving it like 6 to 8 cycles a minute. A cycle is one path and the other path. So if it had a rate of 6, that means 5 seconds one way, 5 seconds another way. If we took our basic cranial rate as 10, it's 3 seconds and 3 seconds. So let's just say it's slower. It's also not global, okay? It is local. So the liver's doing its dance, stomach's doing its dance. There's a bunch of different dances. They're not global, okay? Because they're going to start overlapping each other. So if you really want to know what's going on with the liver, you focus on the liver for a period of time. If you want to know what's going on in the lungs, you focus on the lungs for a period of time. Stop me anytime if you have a question. Same magical chart I showed you with cranial. All of these, if you put your hands over the liver, all of these things are palpable all at once. If there's a pulse going through, if you put your hands softly over the liver, you're going to start to feel that arterial bed starting to move. Respiration I made blue, going slower. Cranial I made red, going slower, and visceral even slower. But they're all happening. How are you going to feel it? You got to kind of tune other things out. It's like having a room of everybody talking, and I can, tune it out and just pay attention to the ones that are making my life a living hell. Okay? So it's like that. You're a mom, you know what I'm talking about. And your husband definitely knows what I'm talking about. Men are good at tuning things out. Turn the channel off. House can be burning down. Off. Watching the game. Okay, so some rhythms are global and some are local. So cranial, respiratory, cardiac, they're global. Means something happens at some center. Cardiac, it's the heart. Respiration, we're saying the lungs are inflating, that's kind of a big center. Cranial, we're saying it's the SBS joint. Spinobasal synchondrosis, that's our center. But then it's palpable everywhere, right? And visceral rhythm is just local. What I'm showing here in that blue arrow is what we're going to try and feel first. We'll go for the difficult stuff first. Trying to feel motility. Motility is what I told you. It's that inherent rhythm that the liver's doing. We theorize it to be less than 0.5 millimeter in its cycle. So if the liver is going through this dance, well, the liver we know is going up, depending on your size, 3 to 5 centimeters. We do that under fluoroscopy. Baral did a lot of research with that, and what he did, and it can be shown that while you're breathing in and out, it's moving up and down. All of your stuff is. When you think of articulations, what do you think of? Bones, shoulders, joints, they are articulating. But articulating is just one thing against another thing, right? So all the stuff on the inside has a normal way that it moves when you breathe up and breathe down. It moves against other organs in a normal way when you breathe up and breathe down. So this motion is happening on top of that diaphragmatic motion. We're going to apply some terms that we're going to throw out later, inspire and expire. I wish they had chosen some other name than this. It has nothing to do with inspiration or expiration, okay? Expire is how we describe it when it's moving toward midline. Inspire when it's moving away from midline. How will you name your diagnoses or your dysfunctions? If I say the liver's in expire, it means it moves easier toward the midline or it's more in midline. Always our osteopathic nomenclature is to name things for the position they'd like to go in or the position of ease.
Sure.
Everyone okay on that? That idea is never going to change. It's not going to change with muscle energy. It's not going to change with anything. If we talk about rhythms, we can always talk about rate, how fast it's going. That never appreciably changes. How will you know if you're feeling a visceral rhythm? By the rate. If you're following it and it's going 14, 16, you're following their breathing. So this will be slower than that. And we will talk about how strong it feels. Strong, we're always going to interpret as health of the organ. In the visceral world, it's a little bit more hard to connect the dots. If you increase the amplitude of the liver, we feel that the energy is moving better to the liver. Have I ever verified that by doing a liver panel and seeing their liver enzymes change? I have not. Maybe you will, but I have not seen that kind of correlation. Let's just say it's the good stuff, good energy, as part of your whole treatment. So who would you do liver treatment to? Well, you could do it to people with liver disease, whether or not you're able to show any actual change. You can do it structurally, and this is how I came into it, okay? When we do big things to the liver here, if you have a shoulder problem, even a neck problem, mid-back problem, me lifting up your liver, which is going to be one of the most beautiful experiences of your life and mine, can override a lot of those problems immediately. It was a game changer for me. It was so quick. And I'll explain how that is. Let's go back to motility. So motility, what I'm doing is I'm showing 3 vectors here that this is what the liver's doing. If you want to put your hand on your liver, if you still have it, it's doing 3 things. It's moving, it's all moving toward midline. So in a coronal plane, it's doing this. In the sagittal plane, it's doing this. And transverse plane, it's doing this. On the order of hundreds of microns. So you're not going to see it. No one's verified it under fluoroscopy. That's expire, inspire, expire, inspire. It's not connected to something on the opposite side of the body. It's its own little dance. Diagnostic tools. We're going to add a big diagnostic tool that I'm using all the time. So last time I added key lesion. I think for some of you, you'll grab to it right away. It was a game changer for me. This is the other game changer as far as diagnosis. And that is you're going to do this rapid assessment. We'll come to this a little bit later. I'm going to introduce the idea now, but we'll practice it a little bit later. I'm going to sweep my hand around the abdomen where it's reasonably safe. Not going up to a woman's breast. I'm not going down below someone's pants line. I'm just going very quick and trying to find that spot that feels different. if I go fast, much faster than you're rubbing your tummy right now, if I go very fast, I'll find something that when I then look at it with a microscope, there will be a problem there. It might not be a problem you're complaining of, but I will find something there. The key lesion and this local listening tool we call local listening, what's different about this and everything else you know diagnostically is these are designed to find places, not to tell you what's wrong. This is, I'm taking you to opposite world again with me. Okay, medical world is, tell me what's wrong, let's look at what the scan says, point to what hurts, let's look at those areas. Nothing wrong with that at all, but the whole damn world is already doing that. So what I want you to be able to do is to find something different. Okay, so if I go rapidly, we'll come to this later, I want to do something else first. So if I survey your belly rapidly and I divide it into 4 quadrants, right, left, upper, and lower, and if I decide to stop somewhere, for whatever reason, there's something that's calling to me, and then I'll find something to change in there. When you operate on that way, in addition to whatever you're being told to do, your efficacy will get better. I'm telling you. Everyone else isn't. Everyone else follows the x-ray, the doctor's orders, the patient's big finger pointing. You do that too, but take 5 minutes of Dr. Insanity and add that in. You're gonna see your efficacy goes up. When you see your efficacy goes up, you're gonna have a little bit more investment and faith in yourself. That their body can show you something that their mind cannot. Morning, sir. My explanation I give to the patients, I've already given to you, the simple explanation. You know, doc, I got a pain here, why are you doing this over here? I just do this, twisting my shirt. Maybe you're complaining of this. Maybe you're complaining of this. I get it when you're saying, I got a problem here that we need to look at that. But if I feel this, and you guys are in the palpation field, there is something that needs to be addressed there. So many of you, just in our simple conversations, when I did some little bit of touching, I said, does your stomach bother you? This, 9 out of 10 times you come out with something. And I'm not asking because I'm a psychic, because I can read your mind, your disturbed little naughty stories. But I can read your body, I can read tension. I go, well that shouldn't be right. What's there? Stomach, GI stuff. What's around here? Constipation. You're learning how to read their bodies, and their bodies are not hiding anything from you. If you have any questions at any time, stop me. This is all just our preamble. Okay, this is gonna be the longest lecture I'm giving. It's just our, can you see? Okay. Our longest lecture of why we should do this.
Did you get the chair here?
No. I feel like moving around. I already know what's on that side. So.
No, I didn't say it.
No, I'm good. So let's talk about mobility. We said everything in your abdomen has to move. It moves because you have an intracavitary pressure. You have alternating positive and negative pressure here. Pressure gets positive here, gets a lot more positive the lower down we go. Everything stacks up on here. Less pressure up in your head. It's changing, okay, so the organs that are moving against other organs, they're doing that with respiration. It's forcing some kind of normal movement. You're not made of bricks and sand and stuff that's just there. It's stuff that's supposed to move, and there's a value to it. Areas that should move a lot have a reason why they should move a lot. Areas that don't move a lot, we can find a reason why they don't move a lot. Areas protected by bones, we can make a structure and function reason why there's bones. Why you don't have bones here, we can make a reason for that also. Articulations, again, we're so used to thinking of articulations as too early for the dance? Okay, too early for the dance. So we think of articulations as bones, everything moving. No, there's certain patterns where everything's gotta move in your gut, and when we change that, you have surgery. Someone has a successful surgery, and they start getting pains every time they eat, they go back to the doctor, and the doctor says, did cholecystectomy, you're fine. What does you're fine mean from the surgeon?
Normal.
No, what?
Normal.
Normal? Give me more. You're right, give me more.
I can't help it.
That's the real answer, okay, but they don't wanna say that. That is the answer. You had a rotten gallbladder, I took it out, you didn't get infected, we sewed it up, looks like the stitch is healed. I can't help you further, okay, but what I did went right. I don't know why you have pain. Do you guys ever get to like assist in a surgery, or have you ever seen laparoscopic surgery? Seen it on TV? That's what I was camera boy. Because I think I told you, I wanted to be a surgeon, that was my whole deal, man. Plastics, ENT, whoever makes the most rupees. First day of surgery, that whole fantasy died. So then when they knew I didn't want to do surgery, I was camera boy for laparoscopy. It's just, here's that, just hold the camera. But if you see what they do in there, if you get a laparoscopy, what's the benefit of it? Well, you heal faster because you're not open.
Yes.
You only have a nice little scar, 2 trocar holes.
Yes.
You look better at the beach. And you heal faster. But when you actually see what they do, okay, they blow you up full of CO2,
Yes.
and then the bovie, which is an electric knife. They just start ginsuing everything by fire. They burn it, they burn the tissues. And about at least 50 times during a normal cholecystectomy, they hit the liver because it's right there by accident. It's not a perfect situation like you think it is. By the way, what happens when they hit the liver with a hot knife? What do you think happens? It jumps away. How does it do it? With the liver-kiss muscle? No, the fascia just recoils. It moves away like there was a muscle that did it. Same as you would do if I came at you with a hot knife. It's a living dynamic area. And then stuff ends up sticking to each other. Normally, we call them
Additions? Additions?
adhesions.
Yes.
Part of normal surgery. So now you got 2 loops of bowel that maybe stuck to each other and didn't unstick to each other. So in peristalsis, that's supposed to be a free area. So when you're eating, you get this pain because every time it hits, there's a hard spot in that bowel. Doctor says you're fine because what she did by their parameters, it's healed fine, and they don't know what to do about that. And they'll be damned if they can find it. You can undo it, and you can find it. You can undo it, and you can find it. So it's normal motion. So there's areas where we want certain kinds of motions, areas where we want very little motion. Yes?
You just said that while laparoscopy surgery, the patient is in anesthesia, right? GA.
Hopefully.
And so in that stage, also the fascia reacts like that?
Yeah. It has nothing to do with being conscious.
Why?
I thought that was the funkiest thing. I asked them,
Is it like the body jumps like, is it a
the liver
zombie or
retracts
something?
away from the knife.
Oh.
There is no liver kiss muscle that I just made up. Okay, you have bands of fascia, you hit that fascia and it pulls back. They hit it a bunch of times. Apparently, your body can recover with it. I asked them, because they used to do this with a VCR tape, appendicitis, gallbladder, and I asked one of the surgeons if I could keep the tape, because I wanted to use it for education at some point. Now you can just Google and you can see all this stuff. But he's like, okay. Because what they do is they tape that, and then something happens to the tape later. Because in case they don't want that being shown in court in case it didn't go right.
Yes.
The tape always gets misplaced or something happens to it.
Yes. And will it be detected?
Everyone
in-
sues everyone in America. This is why. Go ahead.
Will it be detected in ultrasound or something, or it will not? The tape.
No, the tape is, I got a camera in there. I'm seeing exactly what the knife hit, when,
Exactly.
how
That's
they're
why I'm
doing
asking.
everything. And so if you look at that surgery, off topic for a moment, okay? When you get to law has nothing to do with reality. It has to do with people's perceptions. People think surgery is a certain way. And it's just bloody, messy. But then if you want to use that in court, people are going to think, well, the doctor did something wrong. Maybe this is just how surgery is. General surgery, they're doing lumpectomies, breast lumpectomies, and gallbladders, appendicitis, and inguinal hernias. That was like 90% of every day when I was on his service. But people have a perception that it's another way. I'll never forget, a lady came in, she was going to get a lumpectomy. Okay, so they probably aspirated something, they want to take the lump out and make sure she didn't have something. She came into him, and this was an Argentine surgeon, and they're kind of really machismo, like really macho guys. And he's telling her, here's this, you'll need to sign all these things for surgery. She gives him a paper. I want you to sign. And he looked at this, he said, I don't remember exactly what he said, but it ended with, get the hell out of my office. Threw it at her. Once they're your patient, you said, get the hell out of my office, you're getting sued for abandonment. But until that contract is, you're not my patient, he said, get the hell out of my office. Didn't even want to discuss it with her. Then he told me later, she wrote in the paper, the scalpel shall only go this deep into my skin and it shall not go that deep into my skin. He said, what do you think surgery is? You know, it's a knife. You know, you're moving. He says, I threw her out. Get out of my office. She's mad. He says, I can't deal with a person like that because she's already setting up the stage that she's likely to sue me for anything that she thinks, and she does not have any concept of how surgery works to hand me that. And he was right, actually. I wouldn't have been as mean as he was. I would have just said, I can't take you as a patient, recommend you to go to someone that I hate a lot. Office. Okay, but I mean, get out of my office. So if things are articulating, if things are moving against, and we're going to look at abdomen, and this is most of what I'm doing most of the time. We'll look at pelvis and thorax and the advanced cranial, the advanced visceral, and some other ideas. But I'm telling you, most of the time, there's so much gold right here because I can affect shoulder and head from the upper part, and I can definitely do low back bowels from the bottom part. Okay, there's so much that can be done here. You have a double layer system of peritoneum. It has about 120 to 160 cc's of fluid that lubricates it. So it's like a balloon, me sticking my finger in a balloon and getting two layers, one around my hand and one around the rest of the balloon. That's what your peritoneum is in your abdomen. You have a ligamentous system. We don't really think of that, right? Ligaments, you learn, ligaments hold bone to bone. Well, we're going to call ligaments now bands of fascia that hold stuff in place. Okay, their job is ligamentary, is ligament. Turgor, we would say people are, we would grab their thigh in the ICU, they're dry or they're wet. How much water's in your body? Are you blowing up? Water's not moving because you got heart failure, or your body is drying up. That, maybe you're not changing that on the table, but that also will tell you how well their stuff is going to move around, if they're bloated or if they're dry. There's a mesenteric system, which is really all of your bowels, your large bowel and small bowel, are held tightly together by a mesenteric system. And then there's the omental system, which is just a big fat blob, stores energy, and has some strange properties about it. If you get an infection around your gut, sometimes the omentum will wrap around the infection. It's not really understood how it knows or does that. But the body does this when it can't get rid of something, it walls it off. My old Kung Fu teacher when I was in medical school, he used to work on his shoulder now and then because he had a bullet in the subclavian from being mugged and shot here. 4 guys made the mistake of attacking him. He removed one of their testicles. He told me, it's like a move we do. I'm like, so One guy lost some testicles, he beat the other guys, but he ended up with a bullet in his shoulder, couldn't get it out. So one of the things I worked on him is there's a fascial ball all around it, if the body can't get around it. When you see people that have boils on their face, they have a big boil. If you lanced it, it's probably staphylococcus in it, probably. And the body couldn't get rid of it, so at some point it makes a wall. Body tries to get rid of things, and when it can't, it tries to figure out how to live with it. So, again, this is the longest lecture you're going to get. This is my why we should do it. So, if things are supposed to move, what stops us from moving? Okay, adhesions. How do you get adhesions? You get them iatrogenically. You get adhesions from a normal surgery that went well. It's imperfect. They sew things together, and sometimes things are sticking together that shouldn't. You can change this. You can find it, you can change it. Ligamentous laxity, we call it ptosis. Okay, I told you, although you're all young and beautiful now, one day, this is your future. Okay? Everything starts to fall. Same thing on the outside is happening on the inside. Everything's starting to fall. So you suddenly have to pee 3-4 times a night, and you got all these other issues and whatnot. If it's a first degree ptosis, by putting pressure, you might tighten up those ligaments. Second degree, third degree, you might help some of the symptoms, but you're not going to change that. Only the surgeon's going to change that. I've told you who these Amish people are, right? Amish. They're these people in my area in Pennsylvania. They actually originally emigrated between Switzerland and Italy. It's a Christian religion where they don't use cars, they come with a horse and buggy. They're not supposed to use electricity, although they all got an air conditioner in their house. They all cheat a bit. And they like manipulation, and they really don't want to do traditional medicine. You have to convince them. So the reason why I'm telling you is about ptosis. So I had this Amish lady, they all have on an average 8 to 10 kids. Lots of them have more, but very few of them have 3 or 4 kids. Okay, so they have lots of kids. And I had this lady, I treated her maybe 3 times in a year, which is a lot. Okay, they're not gonna come to you chronically. They're gonna come to you with, I fell off the top of the barn onto my head, and this happened, and we're all done right now. Okay, so I had this, they dress in this black. It looks like the 1800s. They have the bonnet on here, and black, and the ones we see, because there's different groups, they're the oldest ones. They don't use buttons, they use big stick pins to hold their clothes together. I haven't gotten one under my nail, but my partner has, so I make sure that stuff is off. You go to do a diaphragm release, you put your hand under it right into a pin. Here's why I'm telling you about ptosis. So I had an old lady, and she said, I had fixed her for some other problems. He said, I've got this other problem going to, that's how they talk. I've got this problem going to the bathroom. Okay, well, what's the problem? You know, this is always my demeanor. I went to school, what's the problem? 3 seconds. She put her butt in my face, she lifted the skirt up, she dropped her drawers, she bent over, and she went, and her rectum turned inside out like a hot dog toward my nose. Yeah, I can't fix that. I don't even think I can forget about it now. So what is that? That is a complete rectal prolapse. Why does she have it? 10 kids, 12 kids. Okay, these are just such common problems. What's my osteopathic treatment for her? Huh? No, there is something. I spend a half an hour talking until I'm green in the face that she needs to go to a surgeon. And she did, but I had just, because other people, because they're uneducated, will take advantage of them. Okay, they love us as osteopaths, they love chiropractors, they love anybody who's not an MD. But other people in our neighborhood will tell them they can fix this by manipulating this and manipulating that. And I said, no one can fix this for you. What's the danger? Why do I want her to go to a surgeon? I'm gonna tell you what I heard. What's the danger? Why do I need her to go to a surgeon?
Because that's the irreparable.
Incision or something.
Because she's going to die. If she will die in her house being stupid or waiting to get the next treatment someone told her to make you go away. Because what will happen? How does she make you go back in?
With the finger?
You got it. Okay, and a friend of mine who's a vascular surgeon told me a trick. Take a sugar packet, sprinkle sugar on it. It'll
Oh.
suck itself back in. Yeah, pretty gross, I know. So these are things I don't need to know either, by the way. At some point, when she's having a bowel movement, her rectum turns inside out. At some point, it won't go back in.
Yes.
Okay, that's when the clock's ticking. You have 6 to 8 hours to get on a surgeon's table. You're gonna lose your whole colon, if not your life. 6 to 8 hours from when something strangulates. Okay, it'll get twisted, when the blood supply's cut off, you can't live like that. You start, first you lose the bowel, and if it's not, so you got 6 to 8 hours where that bowel's dead. And the way that they are, and the way that they think, she could just die overnight. So she did get the surgery, and they're still just crazy people to talk to. But, so things drop. And I don't know whether it's a first or second degree ptosis. I had another Amish lady who, not as dramatic and crazy as that lady, but she said, I got a problem, and she just showed me. She pulled her pants down, and her cervix is sticking out of her vagina. Again, 8 or 10 kids. That's not gonna change, only the surgeon's gonna change. That's not such a medical emergency, she's not gonna die from that. But she said, can you do anything for the aches and pains I'm having? I said, yeah, and actually I was able to help her, but that's still what it is. Okay, but bowel will strangulate, so there's a big difference. So we have things that drop, muscular restrictions, visceral spasms. If you're having like the beginning of biliary problems with your gallbladder, appendix problems, it's going to start to grab muscles nearby. So these are common things.